Okay, so we are going to proceed to our second distinguished speaker for today. He is live from University of Malaya. So before I hand over the platform to him, let me introduce our speaker. Associate Professor Dr. Mohammad Shariff bin Abdul Hamid is a consultant sports medicine specialist under the Sports Medicine Department, University Malaya Medical Center. And he is an academician in the Sports Medicine Unit, Faculty of Medicine, University Malaya. Dr. Shariff completed his undergraduate MBBS training at the University of Adelaide in 1996. He later obtained the Master's Sports Medicine in 2004 and his PhD in 2014. Dr. Shariff currently is a visiting consultant at the National Sports Medicine Center from 2001 until today. His research interests include sports injuries management and exercise prescription for chronic diseases. So now, the webinar series would like to welcome Associate Professor Dr. Shariff. Prof, the platform is yours.
Hello. Can you hear me?
Yes, Prof.
Okay, great. Okay, Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everybody. Thank you so much, Ali, for the kind introduction. And okay, I'm just gonna try and project my presentation here. Boleh nampak tak? Can you see that?
Not yet, Prof. Not yet.
Not yet.
Mm-hmm.
Alright. Okay. Nothing juga.
Not from my side. Nothing from my side.
Okay, I think I forgot to share. Sorry.
Okay, now we can see. Now we can see.
Boleh? Can see that?
Yeah, brilliant.
Oh, all right. Okay, great. So I have to admit, I've made some tweaking in the topic because the topic was given to me initially as sports-related acute shoulder pain and injury. However, given the COVID pandemic situation, we do not see a lot of acute injuries at the moment because of the SOP and whatnot. So contact sport and all the other sports with where acute injuries occur, we don't cover so much. So we are less seeing it, or maybe not at all. So I've removed the acute term there. So at the moment, the topic I'm presenting today is sports-related shoulder pain and injury. Okay, and okay, when we talk about shoulder pain, of course, this is just a brief revision of the shoulder joint. Okay, in an essence, it's an articulation, a shoulder articulation, which composed of several joints. For example, you have your sternoclavicular joint medially, and then moving laterally, you have your AC joint, and then of course your glenohumeral joint. And in many instances, people are referring to the shoulder joint, to the glenohumeral joint, unfortunately. And also there is your scapulothoracic articulation, which is
sorry,
unlike...
Prof.
Hello?
Prof, sorry to interrupt.
Yeah.
Can you change your slide presentation? The mode of the slide presentation?
Oh, terbalik.
Okay. Now okay. Now okay.
Huh?
All right. Okay.
Can?
Just now you have a speaker's note. All right. Good.
Oh, okay. All right. So sorry. So where was I? Okay. So articulation. There's 4 articulation. The previous 3 that I mentioned earlier are considered as a synovial joint. You know, you have all your synovial characteristic of synovial joint includes your articular cartilage, your capsule, as well as your synovial fluid within the capsule. But unlike the other 3, the scapulothoracic articulation is different. It's more like a junction where your scapula meets your posterior thorax, and where it allows the gliding movements of the shoulder complex. So when we talk about shoulder joint, of course, you have your stabilizer, and again, this is just a recap of what everybody already have information on. The static stabilizer, which composed of your bony surfaces, your articulation surface. You know, for example, this one is the glenohumeral joint. You have your head of humerus, which in contact with the glenoid labrum or glenoid cavity, and in essence, the glenoid labrum tends to deepen the cavity, allowing more stability to the articulating humeral head. And of course, the presence of joint capsules and the negative intrasynovial pressure also keeps the two articulating surfaces together. And externally, you also have your various ligaments, which helps to stabilize the glenohumeral joint. Okay? And then you have your dynamic stabilizer. This includes your muscles and your tendon, which support the already static stabilizer, which is already there, and at the same time allow movements or control movements of the shoulder articulation. Okay, and you got your rotator cuff, of course, as well as your periscapular muscles, which includes your trapezius, your deltoid, levator scapulae, and all your rhomboids and so on. Okay, so they work together in providing and allowing movements of the shoulder joints in various directions. Some people consider the shoulder joint as a ball and socket joint, while others, given the lesser stability when compared to the hip joint, some consider it as a saucer and cup sort of equivalent. Okay, and when we come about shoulder pain, the prevalence in the general population, this is based on the study in Netherlands. So they estimated around 6.9 to 26% in the general population. I haven't come across the epidemiology in the Malaysian, in our population, but I think a recent publication by Shariff et al., this include about 783 or something like that of workers, office workers in Malaysia. They did a survey and they found out about 50% of our Malaysian workers have complained of either neck, shoulder, and lower back pain. So, but they did not look specifically on the shoulder joint, okay, complaint of shoulder pain. When we talk about the types of shoulder pain, there are various ways of classifying that. But the one that I use usually is just whether it's acute or chronic, sort of in terms of the onset. Now, as I mentioned earlier, the acute injury, shoulder injuries usually occurs following a traumatic event. Okay? And in many instances, the forces that imparted on the shoulder articulation exceed the ability of the structure to withstand these forces, and hence leads to structural damage. And for example, if you fall on your tip of a shoulder, you get high chance of getting acromioclavicular joint dislocation or subluxation. And for example, also when you land on your flexed elbow, sometimes you can end up having posterior shoulder dislocation. But the common injuries that we see in sports would be with regard to shoulder acute shoulder injury would be anterior shoulder dislocation. This occurs usually when there's a force abduction, at the same time external rotation, which put a lot of stress on the glenohumeral joint. Hence, the glenohumeral joint sublux initially, and then later dislocate anteriorly. This needs to be managed well, especially in the early phase, to avoid complications, which can creep up in the long run of the athletes or the person. And oops. Cut chain. Oh, okay, here we go. Sorry. So the epidemiology of acute shoulder injury is seen much more common in contact and collision as well as combat sports. For example, in soccer, rugby, we also see in martial art events, and the higher risk among men compared to women. And also in those who are younger age group, less than 40, the odds ratio is about 13 times higher than those who are in the older age group. And of course, it's also seen more commonly among people with hyperlex ligament and those who have had a history of previous shoulder dislocation. In Malaysia, we did a study during the sporting event of a Malaysian contingent in the Incheon Games 2014. However, in that event, there's only about 275 athletes participated. We do not see, I suppose, fortunately, we do not see any shoulder injuries in any of our athletes. However, in the Sukip Games 2018, this is a similar study, but it's done locally, involved substantially higher number of athletes, about 6,000 plus, and we're seeing about 323 injuries. And in this event, we saw 21 shoulder injuries. However, the details about the shoulder injuries, other than the acute onset, we were unable to gain any information from the author. Okay. Having said that, acute injury at the moment, we seldom see it now. Okay, in our clinic, in the University Malaya Medical Center, as well as in the National Sports Medicine Center. Also, we don't see that much. We are seeing more of chronic shoulder injuries, and in both settings, also we're seeing more of a chronic shoulder injuries or complaint, and in particular among athletes who perform repetitive movement or overhead movements, and it's been suggested that these repetitive movements ended up in or predisposed to repetitive microtrauma, and if not given enough time for this microtrauma to heal up, then you get cumulatively, you get more injury as the patient or the athlete proceed. Not only we see it in athletes who perform overhead shoulder activities, we also seeing shoulder injuries, chronic shoulder injuries among those who require movement of the shoulder in performing their daily activities or working. For example, painters and those who are involved in heavy lifting of objects. The nature of the work predisposes them to this sort of chronic shoulder problems. If you look at the commonest chronic shoulder injuries, the commonest that we see are listed up there, and in many times they are interrelated with each other, and patients may come in with more than one sort of complaint or diagnosis. The commonest that we see in our clinical setting, both in University Malaya as well as in the National Sports Medicine Center, rotator cuff injuries, and in tendinopathy, actually, what we're seeing more. Sometimes we get to see a little bit of muscle tear together with the tendon injury, but in many cases, it's the tendon being affected. And in some cases, when there is tendinopathy, you get swelling of the tendon as well as the subacromial space may get a little bit narrow. Then you can see shoulder impingement, especially when there is concurrent subacromial bursa inflammation or subacromial bursitis. And if these two, rotator cuff injury and shoulder impingement, are not being managed well, sometimes you can see patient ended up having frozen shoulder, which is also very challenging to treat. Oops. Can't seem to be able to move my. Oops. Okay. So rotator cuff tendinopathy is the one that we're seeing quite a lot, and the pathophysiology is very.
It's interrupting. Again, you have to change the layout. Okay, thank you.
Okay. So I think it keeps on hanging actually. So okay. Anyway, rotator cuff tendinopathy pathophysiology is very complicated. Okay, you can read up. I don't think I'll be able to cover the pathophysiology here. But it's some propose it's intrinsic versus extrinsic cause. And if you look at the remodeling or modeling, tendinopathy modeling by Jill Cook, is also quite interesting. So I encourage you to have a look at that. But for today, I just want to share some of the risk factors of rotator cuff tendinopathy. Of course, the age factor, increasing age, have been associated with more complaint of rotator cuff tendinopathy, repetitive overhead activities, as mentioned earlier, and people with patients with comorbidities, for example, metabolic disorders such as diabetes, and those who are taking medication which can predispose to tendinopathy, such as statins, as well as certain type of antibiotics, are also at risk of developing rotator cuff tendinopathy. And in athletes, the technique of the activity that they perform also have a risk. If they not perform the biomechanical movement well, then they may impart more forces on certain part of the tendon, hence leading to the development of rotator cuff tendinopathy. This is just to show that increasing in age, 20 years old, the prevalence is about 9.7. However, as your age increases in 80 years old individual, it has been reported as high as 62% in terms of rotator cuff tendinopathy. And again, in the working population, it's estimated around 14 to 18%. Okay. Now, interestingly, if you think about rotator cuff tendinopathy in the able-bodied population, may differ compared to those who rely not only the shoulder for overhead activities, but for athletes or a person who is a wheelchair user, they also use the shoulder as a load-bearing joint. So it's possible that the incidence of or prevalence of shoulder rotator cuff injury is a lot higher. In that, this is a cross-sectional study by one of our master student. He looked at all the medical records of badminton players, able-bodied as well as para-badminton player. This is what the result demonstrate in the able-bodied individual or athletes. The overuse injury, rotator cuff tendinopathy, seen about 36.7%. However, the prevalence of rotator cuff overuse injury is higher among our para-badminton player. Just to highlight that, the total number of athletes way low in the para-badminton player, but this is what we have in the National Sports, in the National Institute of Sports. We don't get too many para-badminton player in the national team. Maybe we should get more. Okay? But anyhow, so it does confirm our concern that people who are relying more usage of their shoulder may have a higher risk of developing. Okay? And the clinical features of rotator cuff tendinopathy, of course, they come in with a complaint of shoulder pain, especially with certain movement, in particular the overhead movements. And to a certain extent, it can also affect their activity of daily living. And many also complain of night pain, especially when they lie on the affected side. And for athletes, sometimes the pain is not the main concern. Sometimes the main complaint will be decline in performance, as well as they feel weak when they perform their sporting activities. For example, I had a patient who's a badminton player complaining that he feels that his smashing is a little bit slower nowadays. So he came in with a complaint of that rather than pain alone, because in many cases, athletes, they tend to accept that, it's okay to play with some pain. Right. So in clinical features, in terms of evaluation, of course, inspection in the chronic phases, sometimes you can see muscle wasting, especially if it's been left for quite some time. And palpation-wise, usually they got tenderness, the junction where the most common will be supraspinatus tendon attaches to the humerus. Okay, and then of course the range of motion, in particular the abduction, especially sometimes they can have impingement positive as well. And I'm sure that everybody aware of all the other rotator cuff tests. I mean, specifically in many cases, the empty can test is one of them. They may have positive empty can test. Usually, we proceed with some form of imaging. In many cases, the fastest we perform ultrasound evaluation, diagnostic ultrasound. In many cases, you can see that it's the supraspinatus tendon is thickened and it's appear heterogeneity in terms of the signal that they produce. Okay, instead of appears mixed signal, you can see that there's area of hypoechoic as well as some hyperechoic region. In some cases, you get soft calcification, as well as in the later phase, you can get hard calcification, as in chronic calcific supraspinatus tendinopathy. Okay. Diagnostic ultrasound, however, is operator dependent, and you may get different sort of report based on the experience of the radiographer. So another method that is available is performing MRI of the shoulder that will also display some similar appearance, thickened, mixed signal in the tendon, and in some cases, if there is a tear, you can see the retraction of the torn part, especially if it's a full tear of the tendon. Management, okay, management-wise, this is a very challenging condition to treat. There are, however, some guidelines. In fact, this is a systematic review by Doiron, Kadrin, and et al. They look at all the guidelines available, and they identify about 12 guidelines. However, only 3 are considered to be very high quality. The remaining are considered less in terms of how they come up with it. And of this, the 3 high quality also, they have some disagreement in several aspects. Some considered some form of intervention as recommended, while others, not recommended. So there is still mix in terms of the procedure or the protocol in terms of management and treatment for rotator cuff tendinopathy. Okay. What I'm going to share is what we are doing in our center. Of course, the optimal management we do not yet know. Hence, various guidelines are available, and they seem to be disagreeing with one another. But what they agree is that the first line is a non-surgical approach. Okay, the initial care, especially in when patient came in with symptoms of pain, is actually as a pain control. Okay, and they have suggested several approach. Okay, we also been doing this approach in our setting, the cryotherapy, relative rest, which is easier said than done, especially when you treat athletes. They to get full adherence sometimes is quite challenging. And of course, the use of painkiller. Now, the painkiller, as I mentioned, guidelines also disagree with one another. In our setting, we tend to, first line is using acetaminophen or paracetamol. We try to, we are more, what you call this, be careful in terms of using NSAID. Usually we provide NSAID for a short-term period only, maybe less than 5 days, especially when the pain is not controlled with paracetamol. Then we provide the NSAID. Reason being is that there have been animal studies to say that if you inhibit the inflammatory reaction, then the healing process to a certain extent also being slowed down. And of course, I think this has been covered by Professor Goh just now. Physical therapy, which involve mobilization to restore or maintain range of motion, as well as strengthening of your periscapula as well as the other rotator cuff tendon or muscle, which is still okay. Also included in management of rotator cuff tendinopathy. And the coordination part is more towards athletes in terms of the performing the activities. And okay, I highlighted eccentric exercise because this is in all guidelines they tends to agree on the use of eccentric exercises. This has also been discussed by okay, eccentric exercises. It's been shown by several studies to stimulate healing as well as for pain control. Hence, I suppose it's they extrapolate this from the study on the Achilles tendon as well as the patella tendon. So the other approach, manual therapy, as Prof. Go mentioned earlier, usually it's a combination. So we don't use treatment in isolation. We combine them together. It's been shown some in terms of pain control. However, the long-term effect, people are still not sure yet. In athletes, of course, I think I mentioned earlier, muscle strength and balance are also been emphasized. And in many cases, especially when we talk about return to play or return to sports, we usually would advise them to go for isokinetic muscle tests before they go back. And also, if they come in with recurrent shoulder problem, sometimes biomechanical analysis may be required. And there are some other treatment adjunct. Okay, adjunct means that on top of the other treatments I mentioned earlier, in certain condition, you can also consider the use of glucocorticoid injection, usually combined with the local anesthetic. This is especially when there is subacromial bursitis, or when there is a concurrent early, what you call this, frozen shoulder, you think it's going to develop, then patient or athlete may be beneficial from this injection. Also, we are using nitroglycerin or glyceride trinitrate, which has been shown to improve pain, strength, and function. This is a moderate to strong evidence. The mechanism is not yet sure, but it is thought that the nitrous oxide released by the nitroglycerin enhances blood flow to the tendon as well as enhancing collagen synthesis. Extracorporeal shockwave therapy. We also use this, especially when there is a calcific tendinopathy. And one of the report by DEC showed that 70% treatment success only in calcific tendinopathy. So we also try to use this in that sort of condition. The thing about the ESWT is that it's a painful intervention where you use a very strong ultrasound signal, and in some cases patients are unable to tolerate. So if they're not able to tolerate, then we exclude them from this sort of treatment. And in those who are okay with the pain sensation, sometimes an analgesic prior to the session would be useful. Okay, I'm going into experimental treatment because all those treatment I mentioned earlier. Sometimes we use that, and also we use the adjunct, but still patients are coming with the pain is still there, and they're not very happy, and they require additional sort of treatment. These are some of the experimental treatment that people are looked at, are still looking at, and have shown inconsistency in terms of the findings. So this include your kinesiotape, therapeutic ultrasound, sometimes combined with topical analgesia, laser, especially nowadays. I think they're using high intensity laser, acupuncture, okay, and injection. I also highlighted injection because although we use 1 to 4, some still having symptoms, symptomatic, and difficulty in performing their activities. So we also look at the injection approach, which most of the time the two that we commonly use sclerosing therapy and platelet-rich plasma. So we looked at we did a systematic review on the platelet-rich plasma for shoulder rotator cuff tendinopathy. Now, it shows that in the beginning, there's not much difference between control and platelet-rich plasma. However, in the later phase, 6 and 12 months, especially 6 months, there seems to be favoring the platelet-rich plasma. Bear in mind that there is high heterogeneity, means that there is a lot of inconsistency or disagreement in the terms of the details of the intervention that they use. Hence, heterogeneity is very high. Okay? This is also the same thing in terms of, just now we look at pain, when look at the shoulder function, as in the shoulder pain and disability index, we tend to see that it tends to favor the platelet-rich plasma. This is a systematic review based on the current available data. However, you can see there's only a few studies are there, about 2 studies, and the previous one only maximum about 6 studies. So it's still limited studies available to look at the platelet-rich plasma. Hence, we are looking at this in terms of rotator cuff tendinopathy. Dr. Sameha is looking at this. She's doing an intervention RCT on patient with rotator cuff tendinopathy, and they been randomized to either receive platelet plasma or prototherapy. And this is she presented her findings recently last week, if not mistaken, last 2 weeks, sorry. So this is what she found, that both treatment at 6 weeks, there is a significant improvement in the pain score, as well as early as 6 weeks. And in terms of range of motion or function, you can see that platelet plasma tends to have early onset of improvement in function compared to Prolo. However, this is only based on half of the population for her study. So I think she's at the end of finishing all the study, and I think the COVID pandemic is delayed her completion a little bit. So, and finally, of course, okay, you have your surgery. You can still consider, especially when there is worsening of symptoms and there's poor response to management. And in some cases, when there is a complete tear, then you need to get consult very early so that you avoid the torn parts to be retracted, and which also going to be complicates the surgery if there is to be done. And of course, also when there is a mechanical impingement, as in shown here, when you got a hook acromion or you got osteophyte on the acromion, so they may be benefit from subacromial decompression, arthroscopy or open. Effectiveness, the long-term effectiveness is still we're not sure yet. In terms of athletes, the return to sport guideline, of course, we want to achieve pain-free, but in many instances, it's quite difficult to attain. So we need to balance whether pain-free or pain control. And prior to return to sport, I think I mentioned earlier, there should be a sufficient shoulder strength to allow them to perform their activities. And also through graduated return to play process, we perform sequentially and look at the ability to perform tasks without pain, and at the same time maintaining their fitness and endurance. Okay, sorry, I ran 1 minute earlier. So these are my references for the presentation, and 30 minutes, right? Okay, and thank you so much for your kind attention.
Okay, thank you so much, Professor, Associate Professor Dr. Mohammad Shariff. Very interesting sharing, and I hope we all as a physiotherapist will gain a lot of knowledge from Dr. Shariff from a sports medicine perspective, inshallah. All right, so we move on to our next session, which is a Q&A session. It turns out we have like, I think roughly about 7 questions in the chat box, but I will only be reading 3 selected questions to Prof. Shariff, and the 4 other questions will be answered in the chat box. All right. So the first question is coming from Shelling Bakhzin. The question is, why men have higher ratio than female in injury? Is it due to the structure of the joint, or is it because of the strength of the joint? Can you explain on this?
Oh, okay. A good question. I think you may have answered it to an extent. Okay. On top of that, I suppose the muscle bulk and the power generated from the available muscle bulk is also higher compared to women, and given the brute strength as well as the the type of sports they play also differ. So I think that those two and one of could be contributing to a higher injury that we see in men. Moreover, in the previous time, women do not play much rugby compared to men. Okay, so but now, so it may differ. The difference may not be as high as what it was reported before. So I agree. It's more towards your the physical as well as the type of sports that they play.
Okay, Prof. Second question from Natila. Hi, Professor Shariff. Is that
Hello.
the posture also is the main causes for this shoulder pain, whether come from acute or even chronic? What do you think?
Okay. This is interesting and difficult to say because which come first, whether it's the imbalance causing the pain or the pain causing imbalance. So it's very difficult because when we see patient already having rotator cuff tendinopathy, they got pain. Of course, the movement is going to be different. So when you assess your shoulder disc kinesia, in many cases, it's going to be there. And unless you have a baseline assessment, then that would be useful. But in our setting, in many cases, we see that patient with rotator cuff tendinopathy, with shoulder pain, shoulder disc kinesia are there. So we tend to approach both. Okay, we control the pain, but at the same time, we try to re-educate and correct the shoulder disc kinesia, as well as later on, once the pain have subsided, then we also, if the condition comes back and recurrent, then we also arrange for biomechanical assessment. We do it both in the sports center. Also, we send for biomechanical analysis. In UMMC also, we send to our sports center. They perform all the biomechanical analysis for us. So I hope that answer you. It's difficult to say which one is contributing to each other, but I think they are related, and our approach in terms of management needs to also consider both, include both.
Thank you so much, Prof, for that interesting answer. So the third question is coming from Nur Ain binti Mohammad Sarif. Prof, may I know how is it possible a GH joint effusion, which only can be assessed after MRI is done, may present, even though we have performed a routine physical assessment and it is not diagnosed through the physical assessment?
Oh, okay. Through so you're saying that when you assess, you don't see the effusion?
Effusion can only be determined through MRI test.
Okay. Yeah, okay. I would say that sometimes we can do ultrasound. Ultrasound can also be able to identify fluid in the glenohumeral joint. In fact, nowadays we are also doing ultrasound guided injection. So I suppose because it's a close and deep structure, hence you will not be, it's not like the knee, which is superficial and you'll be able to look at the effusion much. But glenohumeral, I agree, is quite difficult to assess clinically and perform physical examination and say that there is a effusion there. Unless you can see in near the, we call this, long head of bicep tendon, sometimes you can see some changes there and effusion, especially when there is a pain in the long head of bicep tendon. But I agree with you that in many cases, it is able to, you're still able to diagnose using ultrasound, but when it comes out or turns out better in terms of shoulder MRI, in particular, when you perform, we call this MRA, MR arthrogram, okay, especially when you will look at.
All right, Prof, maybe we still have some time to answer two more questions.
Sure.
From Faisal Akmal. Hi, Prof. Thank you for a very nice sharing. Is there any outcome measures used for athletes who have shoulder chronic pain or problem return to sport?
Okay. Outcome. Okay, I suppose there are two. You can either look at your your functional outcome in terms of your score. Okay, people are using disability arm and shoulder and hand dash, and sometimes people are also looking at, I think I mentioned SPADI just now, shoulder pain and disability index. Okay, that is for questionnaire based, and for range of motion, of course, you can the internal rotation and is one of the thing. Do you know humeral internal rotation deficient that we use look at the difference between injured and non-injured on top of the other range of motion assessment that is available, and we do it on the clinical basis.
Okay, thank you, Prof. Last question from Alia
Sure.
Rohini. Hi, Prof. Can you please share how effective are the shoulder special tests, as different tests have different reliability, and how to avoid false positive and/or true negative outcomes while doing the special test during physical assessment? Thank you.
Okay. Good question. Okay, and I suppose shoulder joint being a very complex joint, it's really difficult to isolate individual muscle and tendon. So what they did was that the study that with the empty can test and then with all the other studies that they did is that they did based on the EMG feedback that they do when performing these tests. How effective? Difficult to say. Okay, but the one that it's a combination of your assessment and your clinical findings. Okay, and I don't think you'll be able to get a 0 or 100% specificity and sensitivity, because when you test all these muscles, the other component are also moving. Okay, however, these are the best that we have and the best that documented. So I suppose unless we can come up with a more sort of invasive assessment that specifically target, then until that time, then these are the best that we have. And what reliability? I think reliability also false positive. I think will not be able to fully. Usually we do a combination of tests. Okay, for example, for rotator cuff tear, you combine with the drop arm test and the empty can test together. Those are said, and you combine tests, then your sensitivity and specificity and reliability also increases for a particular structure. And do read up, because I think last time they say it's empty can test. Now they say it's put your thumbs up. So people are looking at other assessment this time, and perhaps this also going to change.
Okay, thank you so much,